7
Okay,
minutes
live.
to 2 minutes, 3 minutes past 7.
Yes, I think we should start, sir.
Okay. Is Dr. Prabhadikari. She's the only speaker who is to join. She will join in the moment, I think.
Dr. Jubin, we are live. We can start.
So, a very good evening to all and a very warm welcome to all our esteemed faculty members. And I welcome you all for the 4th Geriatric Endocrinology webinar today on 1st of October, which is, as Sir mentioned, it is the International Day for the Older Persons. And what better day and what better occasion to learn and discuss more about the issues that we have in the elderly population. And a common issue that we are going to discuss today is about dementia, and that is the theme for today's webinar, Early Interventions in Dementia. And I'm Dr. Aditi Chopra. I'm a consultant endocrinologist at Fortis Hospital, Bangalore, and I will be the host for today's meeting. I'll share my screen. So welcome to the 4th webinar on dementia, early interventions. And without any further delay, it is my privilege and honor to please invite Dr. Ganpati sir, who's the President of Endocrine Society of India, to kindly deliver the welcome notes, sir. Welcome, sir.
Thank you, Dr. Aditi Chopra. Good evening, all. Greetings from Endocrine Society of India. Today, we have the 4th of the series in geriatric endocrinology. We have had themes on testosterone in aging men. Prior to that, we had on hormonal changes in aging, endocrine connections of frailty, all these things. And today, we are having a topic on dementia. And why have we chosen that? Because with the people now aging now, we'll probably witness an epidemic of dementia. So it's very important we identify them. They are a neglected lot. I think we should identify and give them the appropriate care. And you can see the epidemiology-wise, more than 55 million people live with dementia worldwide. And there are at least 10 million new people with dementia cases adding every year. It's a 7th leading cause of death among all diseases and one of the major causes of disability and dependency among older people globally. It has a social and economic impact, not only for the people living with dementia, but also for their carers, families, and the societal at large. And that's one of the reasons we have chosen this topic. I would like to thank our team led by Dr. Jubin for doing a wonderful job on selecting this topic. And once again, I would like to thank the other members, especially Dr. Vinod Kumar sir, for initiating this event. Over to Dr. Aditi.
Thank you so much, sir. And it's my privilege to please invite Professor Jubin Jacob, sir, to kindly address the gathering and also to please introduce our esteemed chairperson, sir.
Thank you, Aditi. Can you share those slides with the CVs on it? So I think the whole idea of the webinar was as endocrinologists, we are probably more interested in recognizing early cognitive impairment and seeing if we can contribute to the care of patients with early cognitive impairment. So it is not a webinar focused on extreme end of dementia, which I'm sure the geriatricians will handle. And with this, I'd like to introduce the chairpersons for today. The next slide.
1 minute, sir.
I think Jubin, you can directly introduce. No need to see the slides.
All right, I can.
Everyone very well.
So I think Professor Vinod Kumar does not need introduction because he's been with us for many webinars previously as well. He is the person who guided us into this webinar series because he is a person who is connected both to endocrinology and geriatrics. He's a former president of professor of medicine and head at All India Institute of Medical Sciences, Delhi, where he headed both endocrinology department and subsequently the geriatric clinic as well. He was a head of endocrinology at PGI Chandigarh as well. He's an emeritus professor after that at St. Stephen's Hospital. And as you can see, there are a huge number of things that he has been involved in the care of older people, including being in advisory panels on aging and health with the WHO, with the Human Rights Commission of India. He's received Lifetime Achievement Awards from All India Institute of Medical Sciences, the Indian Aging Conference, Jan Seva Foundation. So I think we have previously introduced him, and I think he will continue to guide us in the subsequent webinars as well. I'll also have the pleasure of introducing my colleague and friend, Professor K.V. Subramaniam. Next slide, Aditi. Professor Subramaniam is from Visakhapatnam, where he heads the Department of Endocrinology at Andhra Medical College. And as you would be aware, that the last time we had a physical meeting was in Visakhapatnam, where we met, where he organized the Indian Thyroid Society meeting, I think February 2020. After that, there has been no conference after Dr. Subramaniam's last conference in Visakhapatnam. So with this, I'll ask Aditi to introduce our first speaker so we can start without too much delay.
Yes, sir. I'll just share my screen. Sir, are my slides visible, sir?
Yes, you can put it on slideshow.
Yes, sir. Right. So it's our privilege to invite our first speaker, and it's Dr. Mayank Srivastav. He's an assistant professor in the Faculty of Department of Geriatric Medicine at GLN Medical College, Ajmer. And Sir is a member of API IAG and associate editor of GAIG. And he's the organizing secretary of GERICAN 2017. He has more than 10 publications in various national and international journals. He's been a coordinator of various CMEs and speaker and chairpersons at various national and international events. So, sir, it's a privilege to welcome you, and over to you, sir, for the first session of dementia and how we can do an early diagnosis for this. Over to you, sir.
Thank you, ma'am. Am I audible and visible, sir? My slides and I am audible, sir?
Yes,
Okay.
very much audible.
Yes, yes.
Very good evening to all. Thank you very much, Vinod Sharma, sir, for giving me this opportunity to deliver a talk on this topic. And thanks, Dr. Jubin, sir, for inviting me to deliver a talk on dementia and emerging epidemic and early diagnosis. As we all know, the definition of dementia is characterized by a chronic, progressive, gradual decline in a cognitive function beyond a level of normalcy for that age. It predominantly affects memory, thinking, orientation, comprehension, calculation, learning capacity, language, and judgment. And the impairment in cognitive function is accompanied or may be preceded by loss of emotional control, social behavior, and the motivations. And the most important thing to differentiate it with various neurological disorders is that the consciousness is not affected in cases of dementia. Now, if we look at these bar diagrams, these show the life expectancy at birth. We can see that life expectancy at birth was around 40 years in year 1880, which has increased to around 75 years in 2020, and it is expected to increase almost a century, almost 100 years in around 2080 or end of this century. So what is important of this? The importance of this increase in the life expectancy of at birth is that because age is the strongest risk factor for dementia. If we talk of the risk factor for developing of dementia, the age is the most strongest risk factor for developing of dementia. It mainly affects older people, and the most important part of this dementia, it is not an inevitable consequence of aging. Means it is not a part and parcel of aging. It has to be, there are some pathophysiological changes that occur in the body that can lead to the dementia, and it is not in the common language that commonly we in North India we say that satya gaye hain. As the age advances, Bauji ya Mataji satya gaye. It is not like that. It has to be, there has to be some pathophysiological changes. So we have to understand this, that dementia is not an inevitable consequence of aging. Further in epidemiology, dementia, as rightly said, dementia is currently 7th leading cause of death among all diseases and one of a major cause of disability and dependency among older peoples globally. Now, dementia has many physical, psychological, social, and economic impact, not only on the people living with dementia, but also on their caregivers, family members, society at a large. If we talk in terms of monetary basis, the approximate cost of dementia in 2019, and it was estimated to be around $1.3 trillion US dollar, and it is expected to be around $2.8 trillion in the year 2030. So we can imagine the impact of the load of this dementia on a society at a large. Now, if we talk of prevalence of dementia, it is around 20% in the age group more than 90 years, 85 to 90 years. So the prevalence of dementia is around 20% in age group 85 to 90, and it is increased to just double after just 5 years. In 90 to 94 years of age, the prevalence is around 40%. And according to WHO, presently there are around 50 billion people are living with dementia, and nearly 10 million new cases are added every year in the list of dementia, and it is projected to reach 82 billion in 2030 and 152 billion in 2050. And now if we look at the figures 82 and 120, means in next 2 or 3 decades, the number of people who are living with dementia is about going to be double. So we have, it is a very large number of people are going to be added in the list of dementia, and we have to treat them. If we look at this bar diagram, so this shows the prevalence of dementia and the age group. So now it is here at the age of 60 to 64%, the prevalence is around 1 to 2%. And in every 5 years, the prevalence is almost doubling. Now in 65 to 69, it is around 2.5 to 2.5. In 70 to 74, it is around 4%. In 75 to 79 age group, it is around 6 to 7%. And from here, if we look at, it is 75 to 79 years of age. And if we look at the figure of 90, means at the just in the span of say 15 years, the prevalence has increased from 5% to 40%. So this is a rapid rise after the age of 75 years. So there is a steep rise in the prevalence of dementia. So as the age advances, the number of cases, the prevalence of dementia is increased dramatically. If we talk of India, they are, according to 2011 census, there are 104 billion elderly people presently there in India, and it is projected to reach 138 million in 2021 and 194 million in 2031. Now, if we look at the growth rate, it is growth rate of 41%. Means more and more people will be in the elder age group. As the years passes, more and more people will be added to this group with the growth rate of 41%. So that will create a huge volume of elderly people in India. And presently, the prevalence of dementia in India is around 2.7%. And according to the Dementia India report 2010, around 3 million people lived with dementia. And it is estimated to increase 5.29 million in 2020 and 14.32 billion in 2050. Now, again here, the number of dementia patients will increase in 2 or 3 decades. The number of dementia patients in India will increase around 3 times. Now, there is a one term in DSM-5 classification. There is a one term which is added is a mild cognitive impairment. It is just like, as most of the audience is here is the endocrinologist. So like we have a pre-diabetic state, so it is a pre-dementic state. Minimal cognitive and mild cognitive impairment is there. And in India, presently around 15% of the population is suffering from mild cognitive impairment. And the conversion rate from this population to conversion to dementia is around 8%. So this is a huge bulk, and we have to focus on this MCI like we focus in the pre-diabetic age group. It is around, that means after that, with the conversion rate of 8%, every year 1.7 million people will develop dementia every year. And there is a slight demographic difference between the Western population and the Indian population, is that the mean age of presentation is around 66.3 years in India, which is around 10 years younger than the developed countries. And in various studies, it was found that there is a gender equality in India, but this gender equality may differ in some other countries. In some studies, it is found because that the females are more affected because the life expectancy at birth is more for women. So there is a more chances of dementia in women. And there are certain risk factors like smoking or other addictions are more common in males. So there are more chances developing of dementia in male. So in different studies, there are different data regarding gender, but in India, it is almost equal for both the sexes. Now, dementia epidemic is going to be an inevitable consequence of ongoing demographic transition. As we can see that the life expectancy at birth will increase because of development of medical science, because of medical interventions, active management of emergencies. The life expectancy at birth will increase, and that will increase the prevalence of dementia will increase in accordance with the increase in life expectancy at birth. We cannot prevent neurodegeneration, as presently we don't have active neuroprotective drugs or intervention that can exactly halt the development of neurodegeneration. Only what we can do, change in the lifestyle modification, like actively engaging in various activities, doing some physical activities, light exercises, light yoga, listening to music, engaging in some mental work, active management of modifiable risk factors like diabetes, hypertension, dyslipidemia, and early cognition of reversible causes. We'll be talking in the next few lectures in this session only, and active treatment of these early causes and treatment with these are the few modalities that we have to deal with this emerging epidemic. And if we come to the second part of our talk, the diagnosis. According to DSM-5, the diagnosis of major neurocognitive disorder requires substantial impairment in one or the more cognitive domain. Now, this DSM-5 has classified this dementia into two major categories. These are the major neurocognitive disorder and other mild cognitive disorder. The term dementia has been replaced by a major neurocognitive disorder. and that require a substantial impairment in one of the more cognitive domains. When the impairment is sufficient to interfere to perform activity of daily living independently, the condition is known as a major neurocognitive disorder, which is known as dementia. When these impairment are sufficient enough to interfere the individual's activity of daily living, then the disorder is known as a major neurocognitive disorder. And when the person can perform his activity of daily living with greater efforts or with some help, then the condition is known as mild neurocognitive disorder. Now, what are the different cognitive domains that are included in the diagnosis of in the major neurocognitive disorders? These are complex attention, executive functioning, learning and memory, language, perceptual motor or visuospatial function, social cognition. And the cognitive impairment must represent a decline from a previously normal level and should be documented both subjectively and objectively. Now, here are the two terms, that previously normal level. So it cannot be like a person who is illiterate and he came to us for in some dementia clinic, and he is, as he is illiterate, he cannot write, and we say he's lost his ability to write. So it cannot be like that. So first we have to assess for that what was a normal for that person earlier and now what he cannot do, and that has to be documented both subjectively and objectively. For the diagnosis of dementia, to establish the substantial decline in the cognitive domain must be observed subjectively by the patient himself, herself, by the caregivers, by the family members, or by the physician, or by the nursing attendant, whosoever. This decline must be observed subjectively, and that has to be demonstrated objectively on neurocognitive assessment. It is not like that somebody is saying that he is having problem in this, doing this particular task, and when we examine him or her objectively, then he can perform that task. So that cannot be categorized as a decline in the cognitive domain. So these both things has to be there, that the decline in the cognitive domain should be subjectively observed and has to be demonstrable on objective neuropsychological assessment. And that this cognitive impairment must interfere with performance of activity of daily living independently, and must not be explained by other neurological disorders like delirium, and the explainable by specific etiologies that can cause dementia. So before labeling a patient of dementia, there has to be decline in the cognitive domain, which has to be subjectively observed, which has to be objectively representable, and that should interfere with activity of daily living, and that must not be explained by other neurological disorders like delirium, and explainable, and that condition must be explainable by specific etiologies that can cause dementia. Now, the objective assessment of cognitive domains can be done by standardized neuropsychological tests. So this neuropsychological testing is a very, if you go through these tests, it's a very long, take long hours to do a neuropsychological assessment. So we can go for shorter neuropsychological examination tests like mini-mental examination, the Montreal Cognitive Assessment, and mini-cog can be used. But the limitation of these tests is that they cannot sensitively pick minimal cognitive or mild cognitive impairment, cannot be picked very accurately by these tests. And the tests should be individualized according to the patient age, education level, culture, and the region. So the reports of the test should be individualized based on the patient education, patient culture status, whether he can be able to write or not write, he can do the calculation or not. That has to be individualized. It should cannot be generalized for everyone. And how we can early pick up a patient of dementia. So to pick up a patient or with mild cognitive impairment, there should be a high degree of observation for any decline in cognitive function from previous level should be noted. It should be noted we have to make our clinician, nursing staff, family members, they should be educated that if they observe any decline in the cognitive functions from that person can do previously, now he is having some difficulty in doing that task or doing that work, which that should be picked up, and consultation should be sought for that problem. And the treating physician, while evaluating such patient, the treating physician should not only identify the cognitive loss, but also change in the mood, behavior, like apathy, depression, or anxiety. These few psychiatric disorders should be addressed while examining the cognitive dysfunctions. And the history should be obtained both from the patient and the family members or the caregivers, because in the patient of MCI, the mild cognitive impairment, patient himself or herself is more aware of the cognitive loss than the relatives are. So detailed history, including both patient and the family member or caregiver, should be asked for. And the history should be focused on change in the ideal. So the focus should be during history, the focus should be there on activity of daily living. So if we, after taking history, if we go for laboratory investigation, there is a battery of tests which can be done, blood tests like routine CBC, biochemistry, your endocrine profile, immunological profile, toxin metal screening, or any toxin abuse screening, vitamin deficiency screening. So there is a battery of tests that has to be performed when we make a diagnosis. CSF examination may be required in certain cases when we are suspecting some intracranial infection, or for demonstration of tau proteins or other protein structures in the brain. Brain biopsy may be needed sometimes to rule out, to find out the cause of this dementia. Neuroimaging, like we all go for CT and MRI and PET scan to find out the both structural and the functional status of the brain. And the genetic testing may be sometime required, though not routinely recommended, but maybe sometime required when we are dealing with dementia of early onset dementia or the familial dementias. So with this, I would like to conclude my talk that the incidence of dementia will increase substantially as the life expectancy at birth will increase. It is a huge burden not only on the patient and the caregiver, but also on the medical system and society at a large. Early diagnosis and treatment of reversible causes may postpone conversion of MCI to dementia. It is just like we picking up pre-diabetic and we are putting him on lifestyle modification changes and we are delaying the development of frank diabetes. The same may be applied to the dementia. We need to pick up mild cognitive impairment early. We need to intervene in that age, at that time, so that we can at least postpone the development of dementia for some time. And definitely it is an emerging epidemic which needs awareness, education, and action plan to deal with this epidemic effectively. With this, thank you very much, and we hope all our elderly to be as cheerful and as healthy as this couple is. With this, thank you very much. Thank you.
Thank you very much, sir, for the lovely talk about how to diagnose dementia early and act early. So going to our next talk, our next speaker is Professor Prabha Adhikari, ma'am. And just share my screen. Professor Prabha Adhikari, ma'am, is a professor and head at Unapoya Deemed University. She served as a former HOD at Manipal Academy for past 32 years in the Department of General Medicine. And she's the immediate past president of GSI, and she has more than 300 publications, and she's received more than 20 academic awards and also has more than 36 research grants to her credit. So it's a privilege and honor to welcome you, ma'am, for the next talk. And the topic for the next talk is how we can intervene, like multi-component interventions for early dementia, ma'am. So it's a pleasure to welcome you, and over to you, ma'am, for the next talk.
Adhikari, you're muted.
Can you hear me now?
Yes.
Yeah. So thank you for the introduction, and I will share my screen now. Can you see the screen now? Yeah. I bring greetings from Unapoya Medical College, which is recently with the Department of Geriatric Medicine recently getting recognized by NMC for 2 MD seats. And I'm very proud to be starting the program. So all of us, I think that for the endocrinologists, all of you know that the guidelines say that all geriatric patients should be screened for geriatric syndromes, of which cognitive impairment and depression forms a very important component of mental health, and early detection of mild cognitive impairment or dementia should be performed in all above 65 years of age. So if there was no treatment, probably people would not have asked us to do this, because everybody is under the impression dementia is not treatable, it's a progressive disease, nothing can be done about it. So it's a very depressing, it used to be a depressing field to work on, etc. But now we know that multi-component interventions can reverse mild neurocognitive impairment and early dementia. So that is where we are supposed to be intervening, and not when they have reached the end stage of the disease, like how as diabetologists we deal with end stage renal disease or end stage cardiac disease or end stage retinal disease. So we should not be waiting for that to occur, where patients are fully demented, not able to do their activities of daily living. We should intervene very, very early. So although endocrinologists are busy, diabetes specialists are busy, we can do simple tests like 3-object recall. That's something which will not take a long time. As patients come in, you can just ask them to retain 3 words. All of you know it's a component of the mental status examination. So just ask them to retain those 3 words and then again ask. So that itself will screen for dementia. We can also do mini cog, where in addition to 3-object recall, you have a clock drawing test. And if they score less than 2 or less, definitely they are demented. And between 2 and 4, it could be early cognitive impairment. So even if you have no time to do, we can just do this and put them into an active aging program. So it's very, very important that we pick it early so that we can reverse it. Actually, my previous speaker has told you a lot about what to do if you have a patient with neurocognitive impairment. So we don't use the term dementia at all, even when it's severe dementia, because to prove it is dementia, it is very hard. We need to do neuropsychiatric battery, which can take as long as 6 hours of our time. And dementia patients find it extremely hard to sit with those tests, and they get depressed. So I think we should protect our patients from such lengthy tests and just classify them as major or minor neurocognitive impairment. Minor is when it's not yet interfering with the activities of daily living, and major is the one which is interfering with the activities of daily living. You find such a patient, you check their gait and balance, check for neurological deficits and stroke, check for extrapyramidal signs. What we are seeing is Parkinson's or Parkinsonism is becoming more and more common after this COVID times, either because of the vascular disorders which have become more common, or because of risk factors which are increasing. Also screen for vision loss and hearing loss and check their speech and language. That's all we are supposed to do. Our observation is in diabetic population, this vascular dementia syndrome complex is pretty common. We can't call it as dementia. It could be neurocognitive impairment, minor or major. And in this group of patients, depression precedes everything else. So first it starts with depression, then there is slowing of physical function, and then they end up with dementia. They start off with a minor neurocognitive impairment, and if nothing is done, they progress to dementia. The initial things that are lost in such patients are attention. They will not have attention to what we are talking about. They are somewhere else. Their mind is somewhere else. They will not be able to do any executive function, and they are slow. Cognitive slowing sets in. So this is a very common syndrome, and it could be seen in as many as 1/3 of elderly diabetic patients. So this will progress to dementia if we don't do anything. If you do neuroimaging in these patients, you will find small vessel disease, typically characterized by white matter hyperintensities, lacunar infarcts or microhemorrhages, and of course brain atrophy will be there, and we won't be able to say whether it's a part of normal aging or abnormal aging. So since these people, if they have a cognitive impairment, major or minor, we can say that this is not normal and we need to intervene. So this is a typical finding, and it is a very common finding in diabetic older people. If you do cognitive testing, they may score about 3 score less in MMSE than the normal population. They would not have progressed to dementia, but if you leave them like that, within about 4 or 5 years, they may progress to dementia. About 50% of them will progress to dementia. So we have a window of opportunity for prevention. Here we have to act. We cannot just ignore this and say, this is MCI, this is a part of aging. MCI is not a part of normal aging. It is an abnormal aging has set in, and we need to really intervene. So what do? Should we put them on drugs straight away, or should we go for other interventions? We can send them for neurocognitive testing, detailed. At the least we can do is ACE3, that is Addenbrook's clinical examination, which takes around 30 minutes of our time, and in a cognitively normal people we can do in 30 minutes, and little longer in minor neurocognitive impairment. We can easily do that test. It's validated for India, and it is available in 6 Indian languages, including South Indian languages. So we do that, and there we have clear cutoff for dementia and no dementia. So if they fall in early dementia, we can still submit them to neuropsychiatric battery. The short version of 2 hours is getting validated in NIMANS and just released this Alzheimer's Day. So it will be available to us. We can use that. Otherwise, we refer to psychologists for confirmation of dementia. And then we can use cognitive enhancing agents. We have cholinesterase inhibitors and NMDA receptor antagonists. For mild to moderate disease, we can use any of these drugs. We always start with a smaller dose and then progress. Moderate to severe Alzheimer's disease or mild to moderate vascular dementia, we can use NMDA receptor antagonist, that is memantine. Combinations are not recommended. We'll have to start with one drug and add another drug. If they have Parkinson's disease features or Parkinsonism complex, we can use dopa agonists or levodopa-carbidopa combination. But I have found dopa agonists like pramipexole very helpful in these patients who look so depressed, so slow, cognitively slow as well as physically slow. I've seen that with a small dose, the voluntariness improves, and then you can put them on multi-component intervention. Otherwise, whatever you do, your psychiatrists can't do anything because they are on depression medicines. It doesn't help. You tell them to exercise, they wouldn't have done anything. They just come back like that. And cognitive impairment, because of that, they miss diabetes medications and then come with the severe hyperglycemia, or overtake medications and come with hypoglycemia. So a small dose of pramipexole helps in improving voluntariness for all the interventions, plus they become a little faster, and we have found very good effect with this intervention. So multi-component therapy is recommended as a primary mode of therapy for all early dementia patients, or even moderate dementia patients and minor neurocognitive impairment. It works on the principle that we still have neuroplasticity. So what is this neuroplasticity? All of us know that we have almost 80 billion brain cells, but they don't multiply after a particular age. Nobody is sure up to what age it multiplies. But people say after the age of 5, they don't multiply, but they can only grow bigger, and the neuronal network can improve. That's all. So we have to actually focus on early childhood if you have to have very good cognitive reserve. But however, as we know, brain cells can increase in function as well as size, and it's more with stimulus. And we can always improve our neuronal network. Network can grow even in older people. So we can, if we can't really get more cells, we can increase the size of the cells, increase the function of the cells. So look at this aging brain. We will see what is aging brain and what is dementia. You can see this tree here, nice green leaves, multiple leaves, new leaves will come. This is a young brain. This is the brain which everybody has brain aging. It just doesn't start at 60. It starts as early as in early 20s, and you start losing neurons. You can see that you have lost some neurons, okay, because of aging. But however, there are neurons all over, and they can increase the function and then do the work of the entire brain. And nobody will know that this person has any cognitive impairment. Only that person will know. Oh, I used to remember 10-digit phone numbers. I used to remember the names of everybody whom I met. Now I'm not able to remember. So this syndrome has started much, much earlier these days. Earlier it was like after 60, but then it came to 40. Now even younger people are saying, I can't remember. Because of all our connection to media, and our attention is lost, executive function is lost, and this is happening. And look at the last picture here. Here you can see that in certain areas you don't have cells at all. That is dementia. But even if you have few cells, those cells can do the function of that particular big area of the brain. So that is neuroplasticity. So if we act in this region, these cells will stay with us, or they will do the function of the lost neurons. So how do we do this multi-component intervention? So all of us know exercise, yoga is a wonderful thing. It is it does stimulate almost all parts of the brain. It improves oxygenation, it improves perfusion. So brain is going to be activated. Nutrition is important. People are talking about gut-brain connection and having probiotics. There is a school of thought that addition of probiotics may help in improving brain function. Cognitive stimulation activities which stimulate every single part of the brain. It's not just one. People say, I am doing Sudoku, I am fine. No. Somebody says, I'm doing only crossword puzzle. That's not enough. You will have to have every bit of brain which has to be stimulated. So you need to hear, you need to see, you need to talk, you need to do many things to get your complete cognition or cognition stimulation. Social cognition has to improve. So social networking is very, very important. Meditation, because you need to give your brain a bit of rest as well. You can't be having it all the time active with lots of stresses. You need to give brain good rest. Good sleep is also very important. Outdoor activities, environment, good oxygenation, that itself will really improve brain function. Music and art therapy, like dance, painting, color, flowers, everything is going to activate brain. Lifelong learning. You cannot say, I'm old now, I'm going to sit and relax. You have to learn, keep learning. How our Professor Vinod Kumar is so active. His multi-component activity has made his brain younger than all of our brains, because I can see his activity every day and I get motivated by him. He is probably more active than what he was, or as active as he was when he was in his early 20s. You need to have a purpose in life. Somebody who loses a purpose in life is gone forever, because nothing will stimulate him. So have a purpose in life. That will really improve cognition. So we have validated some cognitive stimulation activity module that we got from Newcastle University, which was designed by psychologists, which had activities to stimulate every part of the brain. Like it had something for orientation, language, reminiscence, visuospatial orientation, where they had to draw a road map from the house to the center. Sounds like connecting pictures with the sounds, like animal picture or vehicle picture. Famous personalities, naming, all these active, cooking and tasting, constructions using matchsticks, guessing the price of whatever they bring. So money matters. All these are incorporated in the cognitive stimulation activity. It was a group activity, and it was like a school. They come, they have a name for the group. It will start with a prayer that they all know, and then end with another song which they learn in the center. And we initially tried it in a home for the aged in 3 groups, and we can see that MMSE improved from 18 to 24. We tried it in a elite group which was coming to my clinic. And here also, MMSE improved from 21 to 24. We tried it in a group of people who were cognitively tested normal but complained of memory loss. And it was really enjoyable for them, and they continued on their own because they were cognitively intact. So they said they want to continue, and they were continuing until COVID times. We have tried it in home setting, where our coordinators went and did it on home patients, and it was keeping the dementia patients engaged. Some of them, there was one patient who had stopped singing. She was a singer. Her interest in music was revived. She asked for her instruments like mouth organ and violin, and she started playing it all over again, and she started speaking, and then was doing all crossword puzzles, everything. So we also validated it in an online active aging group during the split times, because everybody was feeling low and depressed, and we did this, and they were enjoying this. It was very enjoyable. We didn't do cognitive testing. So all this idea we got, actually I was working in my middle age in KMC, where we had to take care of 60 frail elderly of a home for the aged. They were just handed over to us, and like as some of them died, more.
I think the internet must have gone off at Dr. Adhikari's place. Aditi, then
Yes. Shall we wait?
Please.
Or-
No, I think Dr. Adhikari is back. I can see her coming.
Sorry.
Welcome back, ma'am.
Yeah.
You can talk without the video.
Yeah. So what we did was we did multi-component intervention for this book. And we found that we did not have dementia as per the prevalence of dementia in India.
I mean, your slides are not visible.
I think the internet connection is weak.
When I was enjoying the presentation, and I was thinking these webinars are a way
Sorry. I
to
do not-
improve our cognition also.
Stable here. So encouraged by this, we started yet another initiative where we started a daycare center for elite elderly.
Going and coming, going and coming.
Vinod, can we start with the next speaker and then come back to Dr. Adhikari when she's back?
I think it's okay. Yes. You can call the next speaker.
Yeah. So Aditi, we can start with the next and then we'll come back.
To Madam. Yes, sir. I'll go ahead. So just moving on to our next talk for the evening. We'll continue Ma'am's talk because of some technical issues. We'll come back to Madam's talk after this talk. And it's my privilege to invite Dr. Suresh Prabhu. He's a consultant endocrinologist at Ganga Hospital in Coimbatore. And he's currently, he has been an ex-assistant professor in endocrinology at PSG IMSR. And he was also a joint organizing secretary at the DFSI Econ in 2019. And he has various publications in national and international journals. Sir, it is a pleasure to have you. And over to you for the next session, where we will be discussing about the endocrine causes of reversible dementia. Welcome, sir, and over to you for the next session.
Thank you, Aditi, for your kind introduction, and thank you, ESI, for just project mining. Few minutes. Is my yeah, thank you, Jimmy. For the next 15 minutes, I'm going to discuss about the endocrine causes of reversible dementia. The past two speakers are see dementia as a whole, but as an endocrinologist, we see dementia as a part of a clinical syndrome. It's a patient present to us. Dementia, according to WHO, is usually a chronic or a progressive disease that leads to deterioration in cognitive function, that is the ability to process the thought beyond what might be expected from the consequence of biological aging. I think the etymology has been discussed well, but I'm going to focus on the reversible dementias. According to meta-analysis published from India, the prevalence of dementia ranges from 10 to 20% per thousand population, but the reported frequency of reversible dementia varies from 0 to 23%. And a recently publication from Dr. Srikanth et al. Shows that the reversible dementia may be as high as 18% in a group of patients with dementia. So this is a mnemonic we used to remember for reversible dementia. The drugs, D for drugs, which common drugs we use for anti-epileptics and antidepressant can cause a reversible type of dementia. Endocrine dementia or endocrine disorders I'm going to discuss. The metabolic one, which include the B1 and B6 deficiency, which can present as a dementia complex. Emotional, which include depression. Nutritional, particularly B12 deficiency and other causes. The T stands for toxic and tumor. Toxic, particularly lead poisoning and arsenic poisoning. Benign intracranial hypertension can present as a dementia. An infection, which include the Ains dementia complex and alcohol. So we know that both excessive and deficiency of hormones have been implicated in cognitive impairment and behavioral changes. And most of them, compared to other forms of dementia, it happens early in life and have a specific clinical findings. Like when a patient of hypothyroidism or something, they have a specific clinical findings where we can identify those type of patients. Compared to Alzheimer's disease, they progress fast, and if treated, they are reversible. And cognitive impairment develop in patients with prolonged and untreated hormone deficiency. It doesn't happen at early stage of disease, but if the disease or if the condition is untreated for a long duration, then the cognitive impairment sets in those types of patients. So with this, I go to my hypothetical first case. This is a 64-year-old patient present with insidious onset of cognitive impairment. And his wife describes that he frequently, recently, forgets about common things. He's a diabetic for 15 years and is on glibenclamide and metformin for past 8 to 10 years. And the patient noticed that his blood sugar is getting better recently. His HbA1c is 6.4 and urine microalbumin is positive, and his renal parameters are elevated. So the calculated eGFR is around 44 ml. So how this correlates with hypoglycemia and dementia? The symptoms of hypoglycemia varies from neuroglycophonic and neurogenic. The neuroglycopenic symptoms include cognitive impairment. When a patient have a recurrent and severe hypoglycemia, it actually presents as a cognitive impairment and memory loss. And then increased risk of degenerative dementia has been observed in diabetic patients in several epidemiological. Not only it causes dementia, but it also associated with degenerative dementia in patients in several epidemiological studies. And this is a meta-analysis which was published recently in 2021. And it actually shows the association between hypoglycemia and adverse events in elderly patients. In that, they found that among 9 studies, the hypoglycemic episodes were associated with dementia with a pooled odds ratio of around 1.5, more common in diabetic patients who have recurrent hypoglycemia. And this is a representative visual of hypoglycemia in a patient similar to what we see in our patient. This patient's HbA1c is 6.5, renal impairment. So this CGMS may unmask hypoglycemia in those type of patients. So when you do a CGMS, these patients may have a recurrent early morning hypoglycemia, which in turn accumulated and end up with a dementia after long duration. And this is the flowchart which shows how dementia happens in hyper and hypoglycemia. So hyperglycemia, by causing oxidative stress, advanced glycation end product, and endothelial dysfunction, leads to micro and macroangiopathy, which in turn lead to cognitive impairment, or it may be associated with other types of dementia. Hypoglycemia recurrent hypoglycemia particularly may lead to cognitive impairment, which is much common in elderly patients. So coming back to patients, any patients who present with unexplained hypoglycemia, we should suspect renal failure. And if you want to unmask hypoglycemia in those type of patients, CGMS will definitely help. And one of the important changes, what we should do in those type of patients is to avoid long-acting sulfonylureas, which can cause hypoglycemia. And these type of dementia may overlap with other causes of dementia, which include vascular and degenerative dementia. So as I already mentioned, alcohol is one of the important causes for dementia when they use for a long time, and it particularly affects the recent memory and not the remote memory. So with this, we move on to a second case. This is a 36-year-old female patient present with memory loss for 3 months duration. When we examined, both recent and remote memory was affected and was unable to carry out her day-to-day activity. The MMSE could not be carried out because patient was not following the commands, and there was no focal deficit and DTR was normal, except in an investigation there is a slightly elevated TSH, and the neurologist asked for a thyroid antibody, which was elevated. The thyroid anti-T2 antibody was 1323 and anti-TGA was 2089. So this is a patient with Hashimoto's encephalopathy presenting with cognitive impairment. We know that Hashimoto's encephalopathy can present in two ways. One is an acute stroke-like pattern where the patient comes with focal neurological deficit, and our patient who present with a diffuse progressive pattern characterized by progressive dementia, cognitive impairment, and hallucination. And the mechanism of dementia is not related to hyper or hypo. It seems to be autoimmune, and the treatment with steroids seem to improve the outcome of the patient. If it is not working, probably we have to add on immunosuppressive therapy also. But prognosis is not universal. There may be a partial or complete neurological recovery that can happen in around 90% of patients. And this is a case report which is published from Delhi, which shows a similar patients who present with progressive dementia. After diagnosis, it actually reversed to normal when treatment with immunosuppressive therapy and steroids. So a few words about autoimmune dementia. Any patient who present with subacute onset, rapidly progressive and often flexible course, we should suspect autoimmune dementia. It may be associated with other specific autoimmunity, and particularly the autoimmunity associated with thyroiditis, the response to immunomodulators and steroids, and the differential diagnosis include anti-NMDA receptor encephalopathy. So with that, we move on to a third patient. This is a patient who present a 60-year-old female patient present with progressive cognitive impairment and dementia. Except for a recurrent abdominal pain, she doesn't have any other complaints for which she was evaluated and found to have a renal calculate. Her medical condition include a systemic hypertension for which she was on telmisartan and hydrochlorothiazide. His MMSA was 15/30. The MRI shows mild cortical atrophy with a non-specific periventricular lesion, and his blood investigation was normal except for an elevated calcium, which is 12.9, and albumin of 2 milligrams per deciliter. I think important to do a PAT sample of that one. When you correct for albumin, it comes to around 14.5, which is a severe hypercalcemia. So we know that the neuropsychiatric manifestation of hypercalcemia is poorly correlated with serum calcium levels. A patient with 16 calcium may be asymptomatic. Another patient like this was 14.5 may be asymptomatic. The mechanism responsible for this is unknown, and hypercalcemia with hyperparathyroidism is associated with irritability, psychiatric symptoms, and depression. And brain imaging study, functional studies have shown that there is reduced cerebral blood flow to certain areas of cortex, which include the frontal, temporal, and postcentral gyrus, which seems to be improved after a parathyroid activity. So this is a case report where a patient with hyperparathyroidism present with a reversible cause of rapidly progressive dementia. This patient is around 73-year-old, and after treatment, the patient got improved. There's another case report of dementia as a presenting symptom of primary hyperparathyroidism, which has improved after surgery. So hypercalcemia and dementia in a patient with hyperparathyroidism, they may manifest as a rapidly progressive dementia with many neuropsychiatric symptoms. The classical presentation, what we see earlier, like the stones, bones, and abdominal bones and cyclic bones are uncommon now. We see more and more asymptomatic patients who pick up during a routine examination of blood tests. And the importance of two things: one, a PAT sample with calcium and albumin should be done. Another thing, when a patient is on hydrochlorothiazide or other drugs, which may unmask an hypercalcemia which is present in few of our patients. And the cognitive impairment due to hypercalcemia is usually reversible. Not only hyperparathyroidism, both hypoparathyroidism is also associated with dementia. Chronic untreated hyperparathyroidism may lead to hypocalcemia and hyperphosphatemia, which in turn lead to calcification of certain areas in the brain, which includes the globus pallidus. Calcification of the basal ganglia leads to extracerebral symptoms, and calcification of the cerebral cortex may lead to a subcortical dementia because of its connection with the corticobasal area. The impairmentation in pseudo-hyperparathyroidism is not related to hypercalcemia, but is related to GS-alpha. So this is a systematic analysis regarding hypoparathyroidism and cognitive impairment. In that, they have included several case reports and case series. And finally, in conclusion, they say that the presence of neuropsychiatric dysfunction of hyperparathyroidism appears to be consistent and poor finding in those studies what they have included. So this is my fourth case. It's a 26-year-old patient present with a history of menstrual irregularities and hirsutism, initially treated by her gynecologist as a polycystic ovary and referred to an endocrinologist for evaluation of hirsutism. She gives history of Cushing's in terms of abdominal striae and proximal myopathy, and also increased forgetfulness and decreased grades in her college. And on evaluation, she found to have elevated blood pressure and HbA1c, suggesting diabetes and hypertension. And the Cushing's was confirmed by screening and also subsequently by imaging. So how corticosteroids affect the central nervous system? We know that in our clinical practice, we see several patients when introduced steroids may present with what we call it as steroid madness or steroid-induced psychosis. So glucocorticoid excess or deficiency leads to depression, euphoria, psychosis, apathy, and lethargy, which can manifest in our patients. And in a rodent study, it was shown that both glucocorticoid and mineralocorticoids are expressed in hippocampus, hypothalamus, cerebellum, and cortex. When prolonged exposure to glucocorticoids leads to neuronal death in the hippocampus, which is similar to Alzheimer's disease. And this is one of the reasons for a cognitive function impairment in patients even after the cure of Cushing's disease. This is the case series where they have included 72 patients who got cured of Cushing's disease after treatment, but they continue to have cognitive impairment even after their remission from Cushing's disease. And this seems to be related to the CNS involvement of corticosteroids. This is my fifth case. This is a 65-year-old diabetic patient, present with progressive dementia, difficulty in walking and memory loss. The patient was on metformin 1 gram twice daily and sitagliptin for the past 6 years, and the patient known to have hypothyroid for the past 20 years. And an examination, tendon defects were exaggerated except for the distal ones and an extensor plantar reflex. The complete hemogram is suggestive of megaloblastic anemia with peripheral smear cells, macrocytosis, and hypersegmented neutrophils. And this actually diagnosed a B12 deficiency. So we know that B12 is a cofactor for DNA synthesis and an important the synthesis of myelin. And those with deficiency of B12 present with peripheral neuropathy, blood cell disorders such as pernicious anemia, they are also present with cognitive impairment if it is not treated early. And it has been reported that an average of 6 to 30% of patients shows B12 deficiency due to metformin use. Any prolonged metformin use, particularly in elderly patients, particularly a vegetarian diet, they tend to develop B12 deficiency. And I included B12 deficiency because pernicious anemia is a component of polyglandular syndrome, which involve multiple endocrine glands. So we should suspect B12 deficiency in dementia in patients who are on long-term metformin, vegetarian diet, and an associated hypothyroidism to rule out any polyglandular syndrome. And this is a study case report of 2 cases where a patient present with dementia with B12 deficiency. And if you see the signs and symptoms of B12 deficiency, both cognitive impairment, slow mentation are one of the important symptoms in B12 deficiency. And this is my last case. This is a 15-year-old patient brought by their parents because of delayed puberty. She was normal until 12 years of age, and after that, the patient parents noticed that there is no further progression of height or puberty, and her parents noted that her school performance had deteriorated after that, and she was unable to concentrate in the school. And when we do a routine examination, her TSH was elevated and anti-T2 antibodies are positive. So we know that thyroid hormones affect the maturation of neurons and also have an effect on the mitochondrial respiratory activity and expression of astrocyte structural protein. So this is well documented in patients with congenital hypothyroidism. But patients with adult onset hypothyroidism is also associated with memory impairment, irritability, and depression, which get improved after treatment with thyroid medications. Not only hypothyroidism, the hyperthyroidism also have reported to have poor concentration and also memory problems. And several population-based studies demonstrated the association between thyroid dysfunction and Alzheimer's disease. So not only cause, sometimes it can be associated with Alzheimer's disease. This is the Rotterdam study, where they have included 9,446 participants of mean age of 65 years, and they followed up for 8 years. And in the conclusion, they found that high normal thyroid function is associated with increased dementia risk, and thyroid function is not related to vascular brain disease as assessed by MRI. So in any increased TSH in a patient, when they followed up for longer duration, the chances of getting dementia is also increased in this cohort of patients in Rotterdam study. So other endocrine causes of dementia include the apathetic thyrotoxicosis and hypopituitarism and Sheehan syndrome. In several studies have shown to associate with dementia, and vitamin D deficiency in a large epidemiological study has been associated with dementia. So I'm not going through in detail because of want of time. And this is my take-home point. The endocrine causes of reversible dementia are common, and if they're diagnosed early, it is reversible. The early onset, rapidly progressive, and specific clinical features such as hypothyroidism are important clinical clues. Thyroid hypothyroidism, recurrent hypoglycemia, and vitamin D12 deficiency are common endocrine causes for dementia. And we should understand that these may overlap with degenerative dementia like Alzheimer's disease and vascular dementia, and it has to be separated from that one. Thank you. So this is my last slide. I'm just can
you stop sharing?
Yeah.
Thank you so much, sir, for the great presentation and highlighting the various clinical scenarios also for the endocrine causes of reversible dementia. And it was a really enriching presentation, sir. So I think we have Prabha ma'am back. So, sir, can we continue from where we left, ma'am?
I think we can continue from where you.
Yes. So you, ma'am, we welcome you again.
Yeah,
and you
yeah,
really...
I'm very sorry. So I'll just last 5 minutes. Yeah, actually, I had shown you my data from home for the aged. Encouraged by that, we started a daycare center for the elite elderly, mainly because at that time my father had developed dementia and he needed a place to go. So in our own hospital, we started an active aging center. You can see my father here in the group, and I caught hold of his friends whom he still remembered, and all of them under the supervision of physiotherapists, they started this program. And the program very soon expanded to include more elders, and they were meeting every day for exercise and some exchange of ideas. We tried many things with them actually, We started with exercise, healthy drink. We started training them in computers so that they can communicate with grandchildren. Some of them started teaching local languages to our medical students. We had brain stimulation activities once or twice a week. My father enjoyed visiting this center until his last day. Although his cognition did not improve dramatically, he was happier, he was less aggressive, and he was actually not recognizing my mother. He started recognizing my mother. So many things happened. Of course, we had given him some medications. So we added more centers because I was so happy with this intervention that we started a yoga center mainly for diabetic females in our physiology department. And that also caught up as a big center. And I could see them looking happier and much brighter. We had also put up other exercise instruments for them. You can see there, these are all, quite a few in this group are 70 plus, and they are performing for us. You can't believe. Only the trainer in the center is young. All others are above 70. They look the same age in this performance. You can see here, the home for the aged performing for us. This is the 4th center I started under our trust. You can see your 80-year-old is having a birthday and a younger person is keeping her on her lap, and you see the happiness that they share. You can see the creativity. These elders started writing their own songs, compose their own music, and then compose their own dances as well and perform for us. Yoga, you can see here. So many things. So we started as many as 8 such centers in the city of Mangalore. Of course, not all of them ran because it requires a person to drive it. It requires a person to be available constantly, and that will cost money. So we could not offer it free. We tried to make leaders among themselves. 5 of the centers continued to run very well. With COVID, all the centers came to a standstill. Then we thought, why not we go online? So we created this platform, in active aging program, where like yoga was going on, exercise was going on, brain stimulation activities are going on. We included guest lectures, then organized competitions online, in addition to their healthcare through tele consultations. Online dance classes started. So all services under one platform. We taught them how to use Google Meet, and that's how we started. This particular couple was stuck at Dubai in their children's house. And when we asked them to make a poster for World Alzheimer's Day, you can see there, with their children and grandchildren, they made a poster and sent to us, acting as though they had dementia. They didn't have dementia. So they were very happy. They're connecting to their friends here through the platform. Morning one exercise, afternoon one exercise, then some music class, that class, this class. They became very active. So this is yet another poster made by a family with a person with dementia. You can see how happy they seem to be. So we could do anything online, although it was not as effective. We could at least give them that connection. So this is this year's World Alzheimer's Day. We've added more and more activities. We have started a program of music therapy. So we know even music can help these people. And we've started, added music therapy to the component of exercise and other things. So I conclude for giving me this extra time. So I feel the day we stop being active, the day we think it's enough, that's the day brain degenerates. We may have a dementia gene in us. We may have white matter hyperintensities in our brain. But if we stimulate and keep the existing neurons active, we can really, really postpone dementia or even prevent dementia. If I'm going to get dementia at 65, I can just push it to 80. If I'm going to get it at 80, I can push it to 100 by keeping my brain active, body active, and soul active and socially connected. So that's all I want to say. And I strongly believe that it is possible for all of us to be encouraging our patients, especially our diabetic patients, since it's an endocrinology forum, hypertensive patients. These are the people who are at risk of developing diabetes. Motivate them to be active and connected. Thank you. So this is my mother whom I lost just a few months back. She had almost 130% cognition because she was so well connected, full of hobbies, full of creativity. She at 95, her memory scores were like, if you had something to measure, it would be 130%. She would remember every event, everybody's birthday, and everybody. In fact, we would be surprised how I may not remember my own grandson's birthday, but she would remember it. So because she was so, her brain was all the time active.
Thank you so much, ma'am. It was a great presentation, and it was really a pleasure to hear from you, your experiences, and especially your contributions in this field, and how multi-component interventions can help in early dementia. It was really a pleasure, ma'am. Thank you so much. And so moving on to the next session, we have question answer sessions. So I think Sir Nitin sir is not there. So yes.
Mintu, is there any questions on the chat box?
There aren't any in the chat. I can't.
No, it is. It's on the other chat box where the streaming is going on. If there are no questions, I have a few questions. Now, I think this is for Dr. Mayank. Now, in a diabetic clinic, what would you suggest? I have two sets of patients coming, one coming from the village, may have studied up to 5th class, 6th class, another graduate, postgraduate. What are the screening tests that I should use? Should I use the same for both? I've used MOCA. MOCA seems very complicated because they have to recognize numbers, they have to draw the lines, they have to recognize animals like rhinoceros. Half of them don't, Punjabis have never seen a rhinoceros. So what is your...
The neuropsychological assessment, as we have already talked, that it has to be individualized. You cannot, it is not a generalized that this test is for assessment of, there are certain domains which we have discussed, like 6 domains, and there are certain set of tests for assessing the each domain. And the testing on the neuropsychological testing, that we come to know that this domain is decreasing, this domain is normal, or this complex attention is decreasing, but this calculation and learning behavior is normal. So we cannot generalize the things. We have to go for this test according to the patient education level, their understanding, her religion, her reason from which he is coming. So we cannot generalize it. We have to be individualized according to the patient education level, patient reason, patient status. We cannot generalize it.
So I'm going to ask you a direct question. Simple Punjabi farmer, studied up to 5th class, coming to my OPD, what should I use?
Yeah, Prabha ma'am will be.
Actually, see, that Hindi MME is validated for people who know Hindi. That was validated by a study, the famous study of dementia prevalence in India, but it is not validated for South India. So there, everything is replaced, like 100 minus 7 is replaced by, like you have 20 rupees, you give 3 rupees to the bus for bus ticket, how much will it remain? That 3 is there. If they can't do that, the names of the days in reverse order. So every bit of complex test is changed there. So that is one thing we can use. The second thing is Minicog can be modified because clock drawing, I don't think illiterates can do. Clock seeing, some of them may do. So you can show them the clock and ask them to read that time. If that is also not possible, you can replace it with asking them to draw a face, draw 2 eyes, nose and mouth. That they'll be able to do often. So we can do that. 3 object recall, even the illiterate can do. So that's not a big thing. So Minicog can be modified. Now Addenbrook's, that is ACE3 has been modified for India, where that constructional things have been modified into, for South India, it is modified into Rangoli, what we draw on the floor. So all those constructional things, they have changed. There are many other things. Addresses of Western people were put there. It's changed into Indian address. So it can be modified, but again, whatever is taxing our patients, we should never do. I feel, okay, you found some deficiency, 3-object recall. That is minor neurocognitive impairment. Put them into multi-component intervention. If memory impairment is really interfering with activities of daily living, you'll have to really send them for detailed neuropsychological testing to see whether it's because of the brain issue they are having this problem or because of physical issues. So such patients we have to send for detailed testing. It is taxing. It is really bothersome for a person who has got cognitive impairment, but we cannot label them as major neurocognitive disorder there. So because of all these issues, nobody does anything. They don't test only, finally. Even neurologists I've seen, people say if you have seen, say, 50 to 100 dementia patients, you don't need to do anything. That's what Niman's neurologist told. If you have seen 50 to 100, don't go on testing these patients and make them miserable. But if you are new, you do all the tests. You do multiple tests. Don't decide by one test. You can.
Dr. Adhikari, I'm Dr. Meenakshi. I really agree with you, and it was really a brilliant thing what you're doing there in your area. I'm really impressed. I would like to share one of my experience today only. Today was 1st October, the Older International Day for Older People. So we conducted an camp in one of the ashrams here. And, you know, there I met a female who had this complaint of memory loss and memory impairment or neurocognitive dysfunction. She had that, and she had shown to a neurologist who had ordered some list of investigations to her. And to my surprise, she came with the reports and showed it to me today. And she had B12 and folic acid deficiency only. And I suppose before your presentation, the reversible causes of dementia, that definitely need to be looked into.
Yes.
And the second thing which you talked about, that if it's not that when we are seeing patients in our OPDs, while talking to them, so we, as you said, that when you have seen patients, you come to know that, yes, they have some memory impairment or they have some neurodegenerative issues, because putting them to those all neurocognitive functional tests is really bothersome. And at the end of the day, you don't have to do much. Ultimately, what you have to do is their active aging and, incorporate them into, or you make them to indulge into daily activities, improve their daily activities. So that's going to help them. But one of my question is that once we're evaluating these patients into our OPDs, we do activities of daily living, then we do instrumental activities of daily living. But do we have some specific tools for Indian patients for checking their instrumental activities of daily living? Because what I came with was the Western only. Because for Indian people, we have a different type of activities which we expect our elderly people to do as they age. And the other thing was the depression scales. What depression scales we use, maybe it's slightly different for our patients, our group of patients. But we don't have much validated scales for depression and quality of life for Indian setting. Do you have anything to say regarding this?
Yeah, again, instrumental activities of daily living. If you ask my mother, do you go out to go to the bank? Do you go and bring money from the bank? Do you use a vehicle? She has never used it all her life. So where is the question of asking such questions? Whereas she has been knitting. So are you continuing to knit? Are you continuing to do something else? Like she's making lots of things out of waste. So that would be her instrumental activities of daily living. So it will be individualized actually. So again, the geriatric depression scale is validated for India in all the languages. However, even if you take a person with Parkinson's, he would have given up all his activities because of his physical disability. And we label him as depressed. It may not be actually true depression. Again, the psychiatrists will use DSM 4 or 5 criteria for depression as well to diagnose depression. So they will validate whether it's true depression or not. But we can screen, that's all we can do. And if you have doubts, we have to take our psychiatrist, psychologist's help as well.
Yeah, thank you. Thank you. That's a good piece of
And
information.
I would like to add one more thing, that if we go for a psychological assessment, a neuropsychological assessment, the process is too lengthy. It takes at least 4 to 6 hours to complete assessment of one patient. And after that, we need to compare it with the person with the normal for that age. Suppose we are assessing a patient of 65 years of age, and first we have to assess that patient, and if the patient is having more neurocognitive disorders or more neurocognitive decline, it will take much longer time. It may go up to 8 hours. It depends on how much neurocognitive impairment the patient is having. And after getting a result of 6 hours, then you have to compare it with the normal person of 65 of year of age. And you have to consider his education level, his reason, his, as Prabha Madam rightly said, his reason, his culture, his activities of daily living. Then you have to again go to the family member, ask the history, what the normal daily routine activity of that person at home, what were the normal daily activities for that. You have to inquire also that, and then only you can come to a conclusion. So it is a very cumbersome process.
So Niemann's also, they said they're not using neuropsychiatric battery at all, except for an occasional patient. They use ACE3, which they have modified for India. And they use clinical dementia rating scale, where family members' input is taken and compared with that of the patient. So these two tools are enough to confirm dementia. They say that's enough, you don't do anything more. That is, neuropsychiatric battery is mainly for research, and let it remain as a research tool. Let us not harass our patients. That was the opinion they gave us.
Okay.
Yeah, I think. Okay, there was a question, one question in the chat box probably.
Aditi, there is one question. We need better imaging modalities, biomarker-based guidelines. And as ma'am said, drugs like pramipexole are safer, improve disability, and reduce psychological mood without need for antidepressants. So I think that's more of a comment.
Yeah, like PET is now a good imaging modality. At least it will tell us whether it's Alzheimer's, whether it is frontotemporal dementia, or whether it is vascular dementia. So it will help us in classification, but it doesn't serve any purpose beyond that. It doesn't confirm anything, because having a PET abnormality, if they are on multimodal intervention, their cognition will be normal. So we have to come back to that patient and his cognition rather than go after imaging. Again, PET is going to cost a lot. 20,000
the cost in a more important is to find the reversible cause of dementia. Rest of the things, we just have to concentrate on improving the quality of life of the patient rather than making a diagnosis whether it is frontotemporal or it is something else. It is just to find out the reversible causes once, like NPH, etc. Otherwise, though, imaging doesn't have much to do. Even the American College of
subdural hematomas, these are some things which we find and we feel happy about it, happy about treating the patient and reversing dementia. So imaging is mainly for that. That is sufficient. I think MRI, if they can't afford MRI or they don't allow one CT scan, at least we can easily do.
Just to screen that when there is no reversible cause is not there. Otherwise, though, not much. And the basic routine investigations, which are treatable, that is important to find
your
out.
endocrine like that will all be wonderful finding for us. We jump with joy when we find something like that.
Yeah, the patient will be okay. Otherwise, it's so depressing.
We should focus to find out the patient of MCI. Like if we want to treat the diabetes, we have to pick the pre-diabetic population. The like is there in dementia. If we are focusing to pick the patient of MCI, pick those patients from your general OPD, and you have to be very observant and while taking the history, but patient and patient relative both should be inquired about the impairment of activity of daily living. If patient is finding some difficulty in doing activity of daily living, you can label that patient as a roughly to be suffering from MCI, and now pick this patient, investigate, try to find out the cause and treat it, so at least we can postpone the development of dementia for few years to decade.
Yes, Dr. Mayank, you're very right. The only problem with dementia is that by the time that gets recognized by usually the patient doesn't come themselves with the complaint of dementia. It is basically the attendants who complain. It's usually said that if a patient themselves comes that I am having a memory problem, it hardly progresses dementia. But when the attendants feel that there is some change in the behavior or something of the patient, by the time the patient is usually highly, they are progressed to dementia. Basically, that is delayed diagnosis. Most of the times, it's the delayed diagnosis actually. And as you well said, that if we can do the cognition test early and pick up them early by doing that, if we pick up MCIs early, then it might delay the onset of dementia. That's right.
It should memory test should become like sugar and blood pressure checkup. At least I said 3 object recall. We can easily do. Mini cog we can do. Like it just takes 5 minutes. If we incorporate in our hypertension and diabetes clinics, I think we can pick them up very early. Like if I do 100, I can pick up 4 people with mini cog score of 2. So I can really do early interventions and really treat them and postpone dementia in that this thing. Although the yield is not so high, but even the 2 to 4 score also, they are mild neurocognitive impairment. We should target them also. Yeah. So it's very easy.
I think we are now far exceeded our time, and I think we have to wind up the discussion. And before I wind up, I think I want to thank Dr. Sanjay and Dr. Vinod. This is also like a multi-component intervention that we are having for aging endocrinologists. We have social interaction with new people. We are having lifelong learning. And I think we are also getting a purpose in life by doing these webinars. So I think, thank you. And so I'll request Dr. Sanjay to give our last concluding remarks. So
can I say something?
Yes, sir.
Well, I think there are few broad points that we have to understand. Number one, dementia is not a hopeless condition anymore. There is a great change in the attitude towards dementia. The few years before, it was said that once you are dementia, you are condemned. That thinking has completely changed. Lot can be done, and as the example given by Mayank about pre-diabetes, same is you catch early. The second main thing which is going on is that I think this webinar also gives a message that early diagnosis by neuropsychological testing or by screening tests is not so convincing in many cases, and it takes time. So what the Western countries are aspiring for is to look for a biomarker. Someone commented about the biomarker. Someone wants to have a confirmed biomarker which can not only diagnose dementia, it should also be able to diagnose MCI. And there are certain markers available now. And for example, beta amyloid protein, not only in the blood, but even in the CSF, even in the saliva, they are being experimented upon, and quite hopefully, to my mind, they have some utility. And even more than beta 42, a ratio of 40/42 is also a biomarker, which is important. Similarly, in the neuroimaging, notwithstanding the cost of various neuroimaging tests, but there is something called amyloid beta scan, which has not arrived in the country. And it holds good promise for the diagnosis of dementia, even in early stages. With regard to the drugs, as Prabhaji has already told, that most of the drugs are not able to significantly reverse Alzheimer. They cannot arrest Alzheimer. But I think the Western countries where the dementia is so common and so rampant, they're desperate to find some drug. At least they want to know a drug which, if somebody even starts taking without dementia, like aspirin for preventing the myocardial infarction or stroke, some drug which will prevent even the onset of MCI later in the years. So there are some good discoveries going on for the drugs also. And these drugs which we have been listening about, donepezil, rivastigmine and galantamine, they have been there for many years now, and they are usually considered to be ineffective. And therefore, people have resorted to some beautiful interventions. And I think Dr. Prabha's presentation has been an excellent example of caregiving. Now, about the drugs, I just want to say that although it was an extraordinary circumstances, but the FDA has released in the month of June a very expensive drug, because this drug is a monoclonal antibody, and it was shown to reduce the amount of amyloid deposit in the brain. And there are also some studies that the reduction in the deposition of amyloid in the brain was found to be parallel in improving the cognition. Hitherto, this parallelity was not proved at all, but this is proved now. So, although there are objections to this early release and into the market about this drug, which is called aducanumab, which is very expensive, it's $56,000 per year. It is to be given in infusion. But I think I want to say the message that active things are going on all around the world. But till that time, whatever we are doing, lifestyle, nutrition, and exercise and all that, that is, of course, is going to stand in good stead. And Dr. Prabha, I'm very thankful to you. You have given my specific example. And thank you very much. I think it's not me, it's God, and who is just keep me enabling. I continued involving myself in spirituality, religion, and I think spirituality and religion and many other things, including lifestyle, they keep you going, of course, with the help of Supreme. Thank you very much.
It's been a great evening today. And like Dr. Jubin said, the fact that we connect with each other, this helps us, of course, learn about managing dementia in our patients, but it helps us prevent cognitive decline in ourselves as well. Please allow me to spend a few minutes commenting on two take-home points. The first point discussed was about screening and diagnosis. All points are well taken, but if you focus on any rigid questionnaire, you yourself will become rigid. And your patient has not read the questionnaire. Your patient is a human being. I would like to share with everybody here, keep on expanding your vocabulary. If you have a farmer, you feel that the farmer has dementia or signs of early dementia, why don't you just take a minute off, keep all the questionnaires aside and say, sir, why don't you tell him about the difference between sugarcane farming and paddy farming? See the light in his eyes. And then he will begin teaching you about the change, the difference in water table, the difference in fertilizer. He will teach you different words from Hindi and Tamil and Telugu and Malayalam. You may not know those words, even though you're a native speaker. And suddenly, now this is speaking in Hindi and Punjabi, then suddenly you will learn, like I learned last month, the difference between parali and pali. One is the stubble that you get after, that you burn after you have harvested wheat. The other is a stubble that you burn after you have harvested sugarcane. But this I would never have known, though I am a native speaker myself. I learned it from the farmer. If my farmer patient is able to teach me this, two advantages. Number one, I know that he does not have dementia. Number two, he taught me something, he is preventing dementia in me. Same for any shoemaker who comes to you. He will teach you 20 names of leather in Tamil or Telugu, which you yourself did not know. So just take time out. How do you make a shoe? If it's a housewife, madam, what is your favorite spice? And even if you know the answer, why don't you scratch your head and say, Do you use the same type of rice to make a dosa and the same type of rice to make an idli? If you get a neutral kind of an answer, then screen for dementia. But if you get a very spirited answer, you've got your diagnosis and you've learned something new. So this is the way to take a history. That was about screening and diagnosis. About management, we learned in school, an apple a day keeps the doctor away. Here, a lemon a day will keep dementia away. Lemon is L for lifestyle optimization. What Dr. Vinod Kumar sir, Dr. Meenakshi Dhar madam say repeatedly, lifestyle optimization. E is for endocrine optimization. M is for metabolic and medical optimization. Any reversible factors, endocrine or metabolic or medical, do screen for them and do fix them up. O is for other support, which means social support. We need to be connected. So lifestyle, endocrine, metabolic, medical, and other support, which is social. And the last N would be nutritional. The example which Dr. Dhar just shared, vitamin B12 deficiency. And because this is the E world these days, if you add to lemon, you add an E, then you make it an E lemon. E would be for ESI webinars. Please keep on joining our webinars. We learn a lot from each other, and let's remain cognitively optimized as a country, as a nation, as a globe, all specialties together. Let's work for the benefit of our patients and our community. Thank you.
What a sweet dish after the dinner.
Lemon sweet dish. Now, another homework for us is to learn about lemon desserts. Jubin?
Yes, so Aditi, we'll
Yes.
stop screening now. And last words from Aditi.
Thank you so much, sir, Sanjay sir, for the lovely concluding remarks. And I think it was a very enlightening and great session on the World International Older People's Day, discussing about dementia. And we thank to all our esteemed faculty members for joining the session and enlightening us. And I thank Endocrine Society of India to giving me this opportunity to share the occasion with our esteemed faculty members. Thank you so much. And
Jai Hind.
Namaste.
Jai Hind.
Good night.
very good night to all.
Good night.
Good night.
Thank you.
Good night.
Bye.